opportunity of proposing its own methodology. So I think depending on what the state thinks is the right way to tackle that, we could try to negotiate something. So we could go into that sort of the considerations in more detail in the executive session about the, potential negotiation levers.
I think that's all I have for now. I had a lot to say last time, so I'll pass to somebody else so it doesn't get too late here.
Just a couple quick ones. So far we've sort of been at the high level of sort of the goals, and here's what we're trying to do, and here's what is on the table. And I think getting into the substance and the meat of like how it's going to do those things and what the risks are and all of the more substantive points of how this would work, I think will be really helpful in the coming months as we evaluate this. So for example, if we talk about avoidable utilization, and that's a key component of making the program work well, what utilization specifically are we talking about, and where is it going, and how is it getting there, right? And so, for example, I mean, you hear about it all the time, the problems with hospitals discharging patients. So if we're trying to avoid ED utilization or post-acute, put people in post-acute care that's appropriate, do we have that? And if we don't, what kind of risk does that create? And this might be like too simplistic, but I understand the whole theory. But so you're trying to put more money into preventative care, but it's not so simple as changing the payment model, and then all of a sudden you'll have the preventative care or the long-term care that you're going to need. So like a hospital can't just get rid of the orthopedic surgeons it has and add mental health and long-term care and primary care. They have people that work there that do things, and just rejiggering is much more complicated. So I guess understanding sort of the risks and abilities to make these changes so that the program and model works well would be really, really helpful going forward. And then I think, a lot of what Member Holmes said, I thought was really thoughtful in terms of like the evaluation and the analysis of what we're doing. So I've been looking at bills that we get for our contractors, and I've been looking at COAG funding budgets, and it's a tremendous amount of money. And I guess understanding what the financial investment is for the state to do it. And I mean by that, I mean for you really, Pat, who's doing the lion's share of this, God bless you. But just to do the application, to do the negotiation, to then come up with a regulatory process, for then like hiring contractors to track all of the total cost of care and the quality, right? Then on top of that, for a hospital to be able to make the transformation, a hospital to have two budgets, a hospital to have two budget review processes, the care board to have two budget review processes, all of those expenses are quite massive. And I want to make sure we're understanding all of those. And they may be like a great investment because there are additional monies that are really important to the state here that we could get, but just really understanding them on a granular level, I think would be beneficial. And then also considering the scope, right? Because if we're talking about whether or not it's a mandatory program or a voluntary program or whatever it might be, insurance, not insurance, all those costs are much better when they're spread out between 14 hospitals that are participating with full commercial participation. Right? So they might not be bearable or worth it if it's two hospitals and no commercial. They might be a really good investment if it's the entire system. And then that also goes back to my first concern or question, I guess I should say, which is whether or not it will work and what the risks are to it working. And if it's only one hospital with 30, 40, 50% of its money, maybe it doesn't solve as much as we had hoped. So then there's an opportunity cost, in that I know you, Pat, for sure, have no capacity to work on any other really substantive reform things. I know our staff and board members don't either. So, right, so we can't do other things because we're very focused on this. And that might be the best thing we can do. But if it ends up being a really small scale and scope, it's just something to consider. I guess the last thing I would just say is the access measures, the utilization points that members Walsh and Holmes made are really important to make sure that we're not losing access and that the model works for our access issues. But then the protection for commercial, and how do we make sure that we don't have really huge, large increases on the commercial market here in the state that we've had for the last several years, and how do we protect against that in this model? So I don't have any questions. If you want to respond, you can, Pat. These are just kind of food for thought things to kind of keep track of as we go ahead.
Thank you, Chair Foster. I'll just respond very quickly. The question about how we can address things like avoidable utilization, given some of what we're seeing in the healthcare system. We've touched on this earlier, but it's really a multifaceted approach where, we look at what can the state do to help shore up those systems. And I can assure you that we're quite focused on that. What are some of the investments coming into the system under a model like this? And how can we best use them? And recognizing the longer time frame in this model, I think does show an understanding on the federal government's part that we're not going to be able to make these changes and solve all these problems overnight. But if we focus on them, we can, resolve them over a time period of a few years. Yes, I think we have to look at what the financial investments required would be, and then your linkage of that to scale and participation levels makes a lot of sense. And we have to determine whether it's something that we want to move forward with, and if so, how to encourage the appropriate level of participation. And then just would reinforce your last 2 points, that access measures are going to be key. And, we want to know what's happening with utilization. Sure, if there's potentially avoidable utilization, are we seeing a reduction in those areas? Maybe partly because of improvements in the system. Are there areas where where we would want to keep an eye on whether people are getting appropriate care? Absolutely. And ensuring that we can address affordability in the commercial market is essential. So thank you.
Yeah, and so much of that turns on the negotiation. So you had on slide 11, you have so many of the benefits, right? And all those benefits influence reimbursements, continued recognition, low-cost care, baseline recognizes past savings. All of those, not all of them, most of those turn on what we get in the negotiation. So how much return on our investment as a state we get will really hinge a lot on what that negotiation looks like, I think.
Absolutely. Yeah.
Maybe stating the obvious. I guess I'm starting to get stressed about that, as I'm sure you are.
Yeah.
Okay. Well, thanks for bearing with us all afternoon here. You're really patient with us, and I appreciate it a lot.
No, I'm happy to be here, and I'm, open door for questions. So thank you for taking the time.
I'll open it up to public comment via the raise the hand function.
And Owen, I just want to say that I would like to go into executive session if we think we can save a few minutes for that.
Yep,
but I think it's appropriate to do that
yeah,
after public comment.
Yeah, I didn't want to keep people waiting who've been patient. Ms. Wasserman, hey, how are you? Julie, are you there? Can you hear me?
Yes, I'm there. Yes, I'm sorry. I just had to click on my camera and my mic. Thank you so much. Boy, long day, lots to absorb here. And I have a number of comments I'd like to contribute. As you know, I already submitted a critique of the AHEAD model to you, and it went to the Agency of Human Services as well as the governor's office. In that critique, I propose that we forego the AHEAD model. Why? because it does not address Vermont's most pressing problems. And in my view, it will distract us from doing so. AHEAD does not address our dwindling supply of primary care physicians. People can't find a primary care physician, and it doesn't even acknowledge that or address that. I suggest that you look at Pat's last slide on primary care, what the Green Mountain Care Board's Primary Care Advisory Committee says. There's 14 or 15 items. I suggest you look at that slide and check off the items on that slide where AHEAD will actually address the issue. AHEAD does not address affordability, it does not address access, and it does not address wait times, as have been addressed. People have mentioned those today. AHEAD does not address the critical lack of funding for mental health and substance use services. And AHEAD also mistakenly focuses on fee-for-service and volume when the actual problem appears to be hospital prices. Many people are concerned about AHEAD's global budgets, locking in current and historical hospital spending, and it denies Vermont the opportunity to address arbitrary hospital prices, reference-based pricing, extraneous hospital costs, and unnecessary ER utilization. And all of those areas are areas for potential savings. And those are off the table once we go with AHEAD's global budgets. And also under AHEAD's global budgets, hospitals could potentially withhold expensive care for patients who need it most. The AHEAD model will dramatically increase administrative costs and complexity, something that we should be working to do the opposite. It's a very complex, convoluted model, and it will be very expensive, as some of you have mentioned. Regarding AHEAD's primary care investments, I'd like to suggest that the $17 million that has been discussed today needs a thorough analysis. And, is the $9 million from Medicare for Blueprint in or out? We need to know that sooner rather than later. I don't think we would want to wait until negotiations. That's a pretty important piece. A third of Medicare enrollees in Vermont are in Medicare Advantage, so they're not even a part of that. I don't know if they were included in or not in the 17 million. Another point is that hospitals are saying that they are not interested in participating in the AHEAD model unless AHS oversees their budgets. So if that's the case, and the Green Mountain Care Board continues to be have its regulatory authorities over hospitals, and also hospitals own the majority of primary care physicians, there could be a pretty low participation of primary care physicians for that $17 PMPM. So my point is that there's a lot of variables here, and that I think it's dangerous to throw around the 17 million until we have a careful analysis of that figure. In addition, we know that given the majority of Vermont's primary care physicians are work for hospitals, what guarantee do we have that those investments won't go to the hospital's bottom line? Now, the same thing happened with OneCare and their primary care investments in 2023, 2024, and also in prior years. As we all know, there's a pending legal action, but we still don't know if that roughly, $20+ million directly supported primary care as it was intended, or did it bolster hospital revenues? Most importantly, there is great concern that AHEAD would in some way disenfranchise the Green Mountain Care Board by shifting oversight of hospitals' budgets to the Agency of Human Services, and also, I might add, the hospitals. We need to clarify where the locus of hospital budget control would be with the AHEAD model before we move much further, because if AHEAD means that the Green Mountain Care Board is disenfranchised and does not oversee hospital budgets, that would be a pretty significant piece of information to have in terms of whether or not we want to go forward. So I suggest that instead of pursuing the AHEAD model, Vermont should do a number of things. I think we have a lot of options open to us, and all of them are within our purview. One would be to strengthen and fortify Vermont's primary care physician workforce through aggressive recruitment and retention initiatives. Another would be to pursue initiatives that improve affordability, improve access, and improve equity. I think that we could spend a fair amount of time in Vermont focusing on initiatives that actually reduce the need for hospital care. Reduce the need for hospital care. We all know what that is. We all know that increased access to primary care, increased access to mental health services, and home health all would help to reduce the need for hospital care. Furthermore, we need to immediately increase funding for mental health and substance use services. A case in point, since August, the Howard Center has closed 4 programs, and they've suspended an additional 2 programs. So 6 programs in all. Those programs are Centerpoint, Intensive Family-Based Services, Autism Toddler Community Program, Public Inebriate Program in St. Albans, Act 1, and the Bridge Program. Now, is that not a wake-up call? I think we have to pay attention to that. And I hope AHS is aware of this, because as we all know, they fund the DAs. Other ideas for ways we can move forward is to standardize hospital prices through reference-based pricing. It's a proven rate-setting method. We can develop initiatives to identify and eliminate avoidable hospital care and unnecessary ER utilization, as I've mentioned. And one other idea is hospital capital expansion. Hospital capital expansion is one of the big drivers of escalating costs. We could think about creating a statewide global budget for hospital capital expansion. So in conclusion, I think we should forego the AHEAD model, which potentially removes hospital budgets from the Green Mountain Care Board, hands them over to AHS, which I'm hearing wants the hospitals to set their own payment methodology. That's not too reassuring. And also forgo the AHEAD model, which will lock Vermont in to an untested model for 9 years. 9 years, allowing for little to no progress on Vermont's most pressing problems. And it's apparent from today's discussion that there has not been enough analyses of what the effects of this model would do. In fact, it's woefully inadequate. And I think in order to move forward, we need some analyses, as as Member Holmes suggested. But one of the biggest problems of all of this is that there has been no public process on the AHEAD model. In my mind, it's a bit of a travesty to be locked in to an untested model for 9 years without a public process to vet the merits of this initiative. Legislators have no idea what AHEAD is. The public, who we're supposed to be serving, has no clue. And even people in healthcare don't know about this 9-year initiative. So I'd like to conclude by saying that we need to initiate a public process with all the affected parties, especially Vermonters, and the AHEAD model needs to be fully vetted in the public arena. Thank you.
Thank you very much, Ms. Wasserman. Mr. Flood?
Good afternoon, Chair Foster. Can you hear me all right?
We can, yes.
No? You can?
Okay, we can hear you.
I am having a little computer problem. If the connection's not good, I'll shut off my video. But I want to add my voice to those that are very concerned about proceeding with this model. I have to agree with what Member Walsh said earlier, that this model is not tightly aligned with what Vermont really needs. And I think that's absolutely true. This, to me, is just another very complicated, very expensive model that will take up all our time and energy, and we will not get to dealing with the issues that really need to be dealt with. There's no mention, really, there's no significant mention in all of this of mental health. There's no significant mention of long-term care. There's no significant mention of services like home health. And without those services being robust, all the focus on primary care in the world is not going to change our healthcare system. And I believe it was Member Holmes who pointed this out, that if doctors can refer to effective services, then what have we accomplished? Now the $17 dollars per member per month is very seductive, and in fact it could be really helpful because it's one of the things that we know primary care needs. We know primary care needs, but we also know from what the doctors tell us that primary care needs a relief from the administrative burden. I see no attention to that in this model. We know that primary care, as I just said, needs referrals to effective services in the community. I see no addressing of that in this model. There is reference to making referrals, but it doesn't do you any good if there's nobody to refer you to. And I think that probably all of you saw the recent letter from 4 emergency room doctors who were pointing out just how bad boarding has become in our hospitals because we don't have services to discharge people to. And in fact, we don't have nurses on floors enough to discharge people upstairs. That's how bad our system is getting. And this model is not going to solve those problems. And in fact, what it's going to do is distract us. Primary care has never been the problem in our healthcare system. It's never been the issue. The issue, as I think most of you actually know, is hospital costs. I heard earlier about hospital pricing. I don't see anything in this model that's actually going to deal with hospital costs or hospital pricing. We know how to do it, as Julie just mentioned. There are techniques we can use to do that. This model doesn't address it, in my opinion. I haven't seen enough evidence to it. And the whole avoidable care problem is not addressed. It doesn't even come up. The term avoidable care is not mentioned in any of this. I have to comment that I appreciate the effort the board made in the past year or so to address hospital costs. And I find it very ironic that the thank you got for that was a bill in the legislature that was going to teach you to be decorous. It's pretty ridiculous. We are focusing in the wrong area. We know what to do, and we're simply not doing it. So what I would like to ask the framers of this model is for specific measurable outcomes. Don't tell me that Medicare is going to give us $17 per member per month. Tell me what we're going to accomplish by that. Before you approve this model, I think you should ask them for measurable outcomes. For example, like, how many more doctors are we going to have in this state? And by when? How many more people in the state are going to have access to a primary care physician when they need it? And by when? I don't see anything like that. How many people in this state are going to have ready access to highly affordable mental health care? I don't think you're going to get answers to those questions, because I don't think the framers of this model have even thought about it. But we need some kind of measurable outcomes here, or I don't see any reason to pursue this model. So I think you can tell I really, this is just another boondoggle. We spent almost 8 years now, start to finish, on the original all-payer model, and we have almost nothing to show for it, in my opinion, nothing. And we're going down the same road again. So without a whole lot more evidence of accomplishment and a whole lot more explanation of how we're going to solve the real problems Vermonters are facing, I think that this board should say no and not pursue this model. Thank you.
Thank you. I have one comment in response, and I actually had a question. So one, I've heard obviously of the interests in having the model regulated differently, or not regulated, or regulated by someone other than the Green Mountain Care Board. I wouldn't support that. I think it would be a less attractive model if that were the case. I think the regulatory apparatus and structure is really important to make the model work well. So to that comment and question, I would not support that. And then the question I had, reference-based pricing has been brought up a couple of times, more than a number of times since I've been here at the board. And I have to say it's quite attractive to me. I think there's a lot of fairness and predictability to it. And I guess the question is for either Ms. Garavich or Ms. Jones. In our design of our methodology, could we put in a reference-based pricing component? So some of our hospitals are very high, like 290, 300% of Medicare. Others are quite a bit lower. Could we set targets based on reference-based pricing and incorporate that into our methodology?
Should I take this
I
on?
will. Oh, go ahead, Shirley. Sorry.
Yeah, I think there are options to construct a global budget, right? So the issue is we start with the historical and how much adjustments you'd like to make. So that's one decision point. Currently, the way we were envisioning is that we do efficiency measures where we look at how efficient hospital is from their operational cost, and then make payment adjustments accordingly to all payers. The issue with reference pricing or any controls on the prices, that the rational behavior would dictate that they would try to maximize with higher utilization to maintain the revenue. So that's why an all-payer rate setting in Maryland moved to a fixed budget model, because as they squeezed the prices, they found out that their utilization went up, right? So at the end, that's the balance, but where you start is important. And there are options in incorporating some of those price adjustments if the state would like to go in that direction. So global budget concept is flexible in a way, right? So we are trying to control both prices and utilization at the same time. You can fix the prices as you start, or you can fix it gradually over time. So there are multiple options under the methodology.
Yes, I think it's true. Our problem is more price than utilization. And so if you're saying lowering price gets you more utilization, which I understand, that sounds attractive to me and like a good way to go about it, because we want more utilization. But obviously, let me finish. Obviously, there's a balance. You don't want to go bonkers and then you're not there. So how do you design it such that you lower the price, get the utilization you need, but then not have it kind of blow out through the roof?
Right, I think you're right. Like, how do you define what utilization you want, right? So you don't want unnecessary utilization. So you don't want wasted services as well. And in the current model, if you just do reference-based pricing, you do not have policy levers to manage that aspect, right? So then it becomes the current incentives remaining, you squeeze down on one side and it will pop up in another. So there needs to be additional mechanism to orient the system to provide, I would say, a quality utilization rather than overall utilization increase. And that goes back to still general concepts around global budget and what you measure and where do you want the transformation happening within the hospital sector.
Could you pay less for certain utilization above certain thresholds so it like minimizes the attractiveness of?
Right, that goes beyond Medicare reference pricing. So that is kind of leaning towards more rate setting methodologies where you do determine the rates based on criteria other than the cost of services, right? So one is to cover the cost, and then you may want to say that, you know, we will provide more than cost for services that we deem needed or high quality or high need.
Okay, is there other public comment? And I accidentally, I skipped over the healthcare advocate and I apologize.
Hi, Chair Foster. This is Charles Becker. I'm here for the Healthcare Advocate today. We have no comments specific to the presentation. I would just say that we did submit a comment letter to the board and to AHS at the end of January. I didn't see that posted to the Green Mountain Care Board website, so maybe some of the folks here on this call haven't had an opportunity to see our letter. And so perhaps I should email your assistant to see if we could get that added to the website.
We'll double check on it on our end and we'll reach out if there's an issue. I apologize. We'll make sure we have it up. Thank you.
Okay, thank you so much.
Thanks for
Chair
flagging it.
Chair Foster, would you object if I made a couple of comments in response to Ms. Wasserman and Mr. Flood's comments?
Please. Yeah, definitely.
Okay. Yeah, just a couple of things. One, you know, in terms of hospital budget review statute, it's very clear about where that responsibility lies. And I just want to clarify that AHS does not, you know, have interest in hospital budget review. So statute seems very clear. I mean, we're interested in the process and the outcomes, but we're not interested in doing it. In terms of primary care access, I would, you know, just note that the idea in, I totally agree that that's critical. And the idea that of, you know, the investment in the AHEAD model, both in terms of overall statewide investment in primary care and the additional PM payments would be to provide resources that would hopefully improve access to primary care. So just wanted to mention that as well. And, you know, agree that there are other aspects of the system that aren't directly addressed by the AHEAD model, although the intent is certainly to see partnerships and resources with other parts of the system. And just to note, and I think we've covered it a bit today, but that there's, you know, these are big problems and require multifaceted responses. And so, you know, AHS is certainly focused on improving system of care and access to care in the system and so forth. So just wanted to, you know, mention that as well. Thank you.
Thank you very much. Okay. I don't see any other public comment. I think we can wrap it up. Oh, one more. Kim Fitzgerald, Mrs. Gerald.
Yes, hi, thank you. I'm Kim Fitzgerald. I'm the CEO for Cathedral Square and we're the statewide administrators of SASH. And so I just wanted to just make a comment that I really appreciate Pat's representation of the concern for SASH if we don't move forward. And I appreciate the board members bringing up, contingency planning if we don't move forward with a head, because we have not heard of any other funding mechanism for SASH moving forward outside of a head. So I just want to appreciate the effort and energies you're putting towards to considering that. Thank you.
Thank you. And thank you for your work there. We were able to visit, was it October or so, and it was really, really lovely.
Thank you.
Any other public comment? Okay, great. Ms. Jones, thanks for spending the afternoon with us. Long meeting, and thanks for your patience.
So Owen,
Thank
if I
you.
could jump in, I don't know if people have time or appetite for executive
right.
session at this point of the day. So maybe I can bring that up in old business next week. If it would be nice if Pat and Shule were there, because I think they could provide some important additional information. So I won't move that today, but I will just say a couple of things I've been holding off on saying. Trying to make sure everybody else had time to talk. So I think one thing that I just want to maybe provide some reassurance on is CMMI does not have the authority to change the state's regulatory process. That is purely a state law issue. So I don't think that is a possibility under the AHEAD model. In the discussion today, I heard a lot of conflation between commercial price issues and Medicare issues, because I don't think that the issues are the same across every payer. And so I think as we continue to refine our discussion, we should be thinking about Medicare, and we have to think about the whole thing, but we also have to think about the payer specific issues. And I think with Medicare, as we talk about a lot, the state compared to other state tends to be low cost. And so a risk there in the AHEAD model is we need to make sure that our total cost of care negotiation results in a reasonable Medicare total cost of care. To me, that's the most essential component to this. And that's something that's difficult to talk about in the public session because it is so heavily negotiated. So that's part of my anxiety about wanting to do the executive session, because I think I want to talk about that with others. And I think to the points that others have made, like in commercial, the issue has been price. And so when you're thinking about, and in terms of the commercial design, like that is not a CMMI issue, that is a state issue. So we have a lot of opportunity to think through what makes sense for the state there. Understanding, of course, that will drive providers crazy if there's not reasonably aligned incentives. So I'll leave it at that given the hour, but I hope that we will be able to go into, we don't have a meeting next week, so it wouldn't be next week, but I hope that we will be able to talk about the Medicare total cost of care considerations, because I do think that for me is the key component post-negotiation that will need to be evaluated, and I'd love to share some thoughts about that. Thanks.
Thank you. Maybe what will make sense for us to do is actually just dedicate a full board hearing to executive session or something, so people don't have to wait around for us to go in. And, it's off-putting to me. I can only imagine what it's like to be trying to participate. And I did just want to give a nod to the public comment and the effort that people put in to critique and provide feedback. It is so massively valuable, right? I've said this for a long time since I've been at the board, really. Sometimes it's like the best thoughts and ideas are from my other board members, staff, guests, but also the public. So this is your own time as far as I understand it. And so thank you for doing it to try and help us make this as beneficial as we can, or to make sure we make the right decisions. So thanks everyone for sticking around and doing that for us, because it's really valuable public service. All right, any old business or new business other than Ms. Lunges? Okay, is there a motion to adjourn? I'll move to adjourn. I move to adjourn.
I'll
I'll
second.
second.
All right. All those in favor say aye.
Aye.
Right.
Aye. We are adjourned. Have a nice evening. Thank you.
Thank you, everyone.
Thank you.